frequently asked questions on adolescent idiopathic scoliosis. What is adolescent idiopathic scoliosis? It is defined by a lateral curvature of the spine, cob angle, of at least 10 degrees that affects adolescents 10 to 18 years of age in the absence of underlying congenital or neuromuscular abnormalities. What is the clinical significance? Most patients with adolescent idiopathic scoliosis will not develop clinical symptoms in their lifetime. Back pain is more common among those with scoliosis. However, it does not result in disability or functional impairment. Curve magnitude does not correlate with back pain severity. Mortality is similar between patients with adolescent idiopathic scoliosis and the general population. A minority of patients who have greater curve angles will develop substantial rib deformities, leading to more serious disease later in life. Clinically significant disease is more likely to occur at a cob angle of 40 degrees or more. Those with progressive scoliosis may have physical pain, cosmetic deformity, and respiratory difficulties ranging from subjective shortness of breath to pulmonary disorders with measurably impaired lung function. These diseases are accompanied by other adverse effects, including social and psychological distress, financial cost, and reduced quality of life. Should children be screened? There is insufficient evidence to assess the balance of benefits and harms of screening for adolescent idiopathic scoliosis in children and adolescents 10 to 18 years of age. How useful is physical examination in detecting clinically significant scoliosis? Scoliosis is often brought to the attention of clinicians by the patient, caregivers, or school-based screening programs. Clinical examination including the forward bend test and use of a scoliometer can reliably determine which patients require further evaluation or referral. The cutoffs at which radiography is ordered vary from 5 to 7 degrees of trunk rotation via scoliometer. Radiography should be ordered for any adolescent with an obvious curve on physical examination or with readily apparent thoracic or lumbar asymmetry in those with a family history of scoliosis, and for monitoring of progression in patients who have been previously diagnosed. What examination or radiological findings warrant referral? Referral for surgery and/or bracing is indicated when the initial cob angle is 40 degrees or more. Observation is generally recommended for patients with an initial cob angle less than 20 degrees. At smaller degrees of curvature, radiographic monitoring for progression every 6 months is warranted, and referral is indicated if the angle increases. Patients with a smaller cob angle and risk factors for progression may also benefit from referral or close observation. Younger age at presentation, especially younger than 12 years, female sex, family history of clinically significant scoliosis, and relative skeletal immaturity are risk factors for progression. Skeletal maturity is generally estimated through radiography of the pelvis to obtain the RISA grade. Grading is based on the degree of iliac apophysis ossification, from grade 0, no ossification, to grade 5, complete bony fusion. Lower grades indicate more growth potential and greater risk of curve progression. What treatments are effective? Treatment of adolescent idiopathic scoliosis aims to reverse, stop, or limit further spinal curvature, and thus, prevent or mitigate symptoms. Management options include observation, physical modalities for example bracing, physical therapy, and surgery. It is unclear whether any treatment mitigates symptom progression into adulthood or improves long-term quality of life.
Audio Jungle. Audio Jungle.